Hi, good morning, good afternoon, good evening to everyone around the world. So we are very delighted to start this ANBIIG clinical case marathon. And ANBIIG, it's the short-term form for Asian Novel Bioimaging and Intervention Group. We are a professional group focusing on training and education. So we have been conducting a lot of training courses during this time of COVID. We have started with a series of lecture online last year, and by now we have started our session 2 about the online training and education, and this will be more focusing on clinical case presentation and discussion. So I'm very delighted today we have 4 experts in the field joining with me to conduct this clinical case marathon, including Professor Haruhiro Inoue, who is the president of JGES, and also the professor and director of Digestive Disease Center at the Showa University Koto Toyosu Hospital in Japan. And together with Professor Hunyan Zhong, South Korea, Dr. Ching-Tai Lee from Yidai Hospital, Taiwan, and also Dr. Xiaochen Ya from Fujian Catholic University Hospital in Taiwan. So today our rundown will include the presentation of different cases, and each of our experts will have around 20 minutes of presentation, and together with a case discussion. So Professor Inoue and me will serve as a commentator and also on the coordination of the questions and answers. So without further ado, may I first invite Dr. Ching-Tai Lee to present his first case, and also with some discussion about the endoscopic diagnosis and characterization of early esophageal neoplasia. Ching-Tai, please.
Thanks, Philip. I share my slide. It's my honor to share my experience about the ANBIIG diagnosis and the classification of squamous esophageal neoplasia. First, I will show you a picture, my past patient. During the early stage, the early lesion was not diagnosed at that time, and 1.5 years passed. The lesion rapidly progressed. So how we to prevent the history repeat itself? I think there are several tips for early diagnosis of esophageal squamous neoplasia. At first, we need to focus on screening for high-risk patients, including the ABCD and head and neck cancer patients. And during the endoscopic examination, we need to clean mucus and the debris with water and gas cone. And we need to give antispasm agents such as buscopan. And most important, we need to spend more time for esophagus. Try to take care of the blind spot and watch the hot zone area for the esophageal lesions. And another important thing is using the image-enhanced endoscopy to increase the detection. Usually, I use the high-definition white light image and then switch to the ANBIIG screening. And if there is any suspicious lesions, magnified endoscopy could give us information using the JES classification. Local staining is also used to see the margin of the suspicious lesions. And of course, biopsy, take biopsy for the pathology proof. There are 4 main risk factors for esophageal neoplasia. we call the ABCD: A, alcohol, beta chewing, cigarette, and ALDH2 deficiency. Another high-risk group is the patient with head and neck cancers. Our study in Taiwan has shown that for the cancer located in the oropharyngeal area and the hypopharyngeal area has higher risk for develop metacoronous esophageal cancers. Our recent study from nationwide population-based study also show that even follow-up more than 10 years, a patient with head and neck cancer also have higher risk to develop the esophageal cancer. Another study from our hospital also show that there is a hot-zone area for development of early esophageal cancer. Usually, we should pay more attention at the lower hemisphere of the esophagus, and the location usually from middle to lower esophagus. This area is a hot zone area for develop esophageal cancer. Traditionally, we use white light image to check the esophagus. Take more time to watch is there any morphology change such as nodular or depressed lesion, and also the color change, the reddish color. Usually if the lesion is a flat-type lesion with small granular change or without irregular surface, the lesion may be located on the superficial epithelium. If the lesion had a large granular change or depressed lesion, the lesion may be invaded to the M3 or the superficial submucosal layer. If the lesion has a large nodule and fold conversion, the lesion should be invaded SM massive. But the accuracy of the white light image is not so good, only 70% in experienced Japan endoscopists. So for the beginner, the accuracy will be low using white light image only. So that's why the image-enhanced endoscopy, especially ANBIIG, developed using the narrowing bandwidth of light. We could enhance our detection. For the suspicious lesion, after switch to the ANBIIG, the background will be changed to the brownish background, and the microvessel will be visualized more clearly. The mechanism of brownish color change of esophageal epithelium is when the cell change to the dysplasia, the layer of the epithelium will decrease. So the light, the reflection of the light will decrease also. So after switch on ANBIIG, you will see a brownish area. Glucose solution is an old method. As we know, the normal epithelium of esophagus contain glycogen. When the epithelium have dysplasia change, the glycogen number will decrease. So after staining with glucose solution, the suspicious lesion will become whitish. Glucose solution had high sensitivity but very low specificity. And also glucose solution have some adverse effect. So currently we prefer use the magnified endoscopy to observe the IPCL of the esophagus. When using the spatial endoscope with the Roon function, we could see the IPCL change if the epithelium from normal to the dysplasia and even progress to the carcinoma. The IPCL, the shape of the IPCL and the diameter of the IPCL will change. Using the new simplified classification for the IBCL and the avascular area, we could define the vascular change and the tumor depth of invasion. For example, the JES magnified NBI classification of IBCL divide the IBCL into the type A normal and the type B1 loop structure IBCL, and the type B2 means thin branch type IBCL, and also the B3 means the thick vessels. Each type of IBCL correlate with different pathology. The performance of JES classification for the type B1 is high. Usually the type B1 IBCL correlate well with the pathology M1 and the M2 cancer. However, the type B2 IBCL is slightly not so good, only half, 55% correlated with the invasion depth of M3 to SM1. And type B3 IBCL is well correlated with SM mass invasion. So now I will present my case to let the audience know how I approach the patient and using the NBI and magnified endoscopy. This is a 70 years old male with underlying DM and hypertension under medical control. The patient had behavior of alcohol and smoking, and he just quit recently. The patient suffered from epigastralgia for weeks and no other symptom signs. The patient received endoscopic examination and shows suspicious lesion over middle third of esophagus. Here is the video of the endoscope using white light image and NBI without magnification. I put the key picture of the lesion over the left side. You could see after switch to the NBI, the lesion become brownish, and there are some enlarged IBCL within the brownish area. After well insufflation, the lesion looks like flat type lesions without obvious nodular change. The lesion occupy more than 3/4 of the circumference of the esophagus. So it's an extensive lesion. The length of the lesion is about 5.5 centimeters. So the margin is more clear after switch to the NBI. So this is a 5.5 centimeter length, more than 3/4 circumferential reddish lesion, brownish color on NBI over middle third. So the question one is, what do you think the morphology of the lesion? I give the reference of the Paris classification. Do you think what kind of morphology of this lesion? Please vote. Okay, now half audience have voted. Okay, most of the audience think this lesion to be 2B lesions, and some audience think these 2C lesions. Okay. Is there any comment from the moderator or other expert? Initially, I think this lesion may be 2C because under NBI, without sufficient inflation, there seems some depressed over the margin of the lesion, but after well inflation of the esophagus, the lesion seems, most of the lesion seems complete flat type. So I think maybe 2B or 2C could be acceptable, but I think most of the lesion may be 2B. What's your opinion, Professor Zhang?
Yeah, I agree with you. Mostly flat lesion, but looks like depressed because of the color is deeper. So if you cut this lesion and then pathologically you can find there is type 2. Focally maybe 2, 3, 2C, but most of the lesion maybe type 2B.
Oh.
Yeah. So after observe the lesion with NBI, then I switch to the magnify function. It's not easy to use the magnify function because it needs a stable hand. So using a special short black cap, it could help endoscopists to stabilize the vision and to check the IPCL. You could see there are some enlarged IPCL. In my opinion, it's more easy to put the lesion in the 12 o'clock to observe the IPCL. And usually check the more uneven area or depressed area because the more advanced IPCL occur over the nodular area or depressed area. So after observe the IPCL, here is the key picture of the IPCL. What kind of IPCL classification of the lesion do you think? Please vote. I also reference the IPCL classification. Type B1 is loop IPCL with a little bit diameter change, caliber change. The type B2 is the branch type and the non-loop IPCL. And type B3 is large, thick IPCL. So what kind of IPCL for this lesion? Okay, I think half of the audience have votes. Most of the audience votes type B1, and some audience votes type B2. Okay. Initially, I checked the IPCL. I think this IPCL belong to the loop IPCL without a large diameter. So initially, I think the IPCL belong to the type B1. But when I prepare this case, I check the IPCL again, and I wonder this area is loop or non-loop area IPCL. So if this IPCL is non-loop, then it belongs to the type B2. But if you think this IPCL is loop, it belongs to B1. what's the opinion from other experts?
So can I comment on that?
Yes. Professor
So
Inoue.
I'm Haru. So I totally agree, Dr. Lee. So most of this is a typical magnifying image, NBI image. The pattern is a B1 mostly, and the only this part is a vessel is actually looks going horizontal, but this is just a single vessel. So treatment from the point of treatment, so B1 and B2, we do the EMR EST. So I think it's okay. So we can accept B1, B2, but so most of the part, definitely B1.
Okay, thanks for the comment. Yep. Okay, the question 3 is what is the estimated invasion depth of the lesions? Please vote. Okay. Oh, I think near half of audience think this lesion is M3 through SM1 invasion lesions. And 1/3 of the audience think this is very superficial lesions. And still have 17% think this is SM massive invasion. Okay. According to the IPCL, if using the it's belong to the IPCL type B1, then the estimated invasion depth should be the T1A EP to LPM. If using the lesion is have IPCL type B2, then the estimated invasion depth will be M3 to SM1. So I will let you know the answer later. Now I will let you see the Lugo standing. Usually I use the Lugo solution with concentration about 1 to 1.5% concentration. After spray the Lugo and using some water flush, and you could appreciate the after Lugo standing, the margin of the lesion will be more clear. So it's extensive neoplastic lesion with Lugo voiding. Okay, the chromoendoscopy with Lugo shows more than 3/4 circumferential extension. We take biopsy. The biopsy only show high-grade dysplasia because the cancer cell did not invade the base membrane into the lamina propria. So the pathology saying it's only high-grade dysplasia. So what's the next step? How to treat these lesions? Close surveillance or endoscopic resection or esophagectomy or CCRT? Please vote. Okay, I think more than 90% choose endoscopic resection. Just as Professor Inoue said, no matter type B1 or B2, endoscopic resection is indicated. And some audience choose close surveillance, and some prefer chemoradiation. Usually, we choose the endoscopy management according to the JES classification. For the type B1, it's absolute indication for endoscopy management. And for the type B2, it's relative indication. After endoscopy resection for the type B2 lesions, the pathology should be checked if there any microvascular invasion. If the lesion invaded to the M3 and without lymphovascular invasion, that's the patient had minimal risk of lymph node metastasis. So no further treatment is needed. But if the lesion is invaded to the submucosal layer or has any lymphovascular invasion, the patient have up to 20% risk of lymph node metastasis. So this kind of situation need adjuvant operation or CCRT. But just I mentioned previously, the type B2 have not so good correlation with the pathology. So if you find there are some area with type B2, you could try endoscopy management first and to check the pathology detail. The JES have published the new guideline for the esophageal cancer for the superficial lesion embedded to the EPA or APM, and with more than 3/4 circumferential extension. Endoscopic resection and the prevention of stenosis should be considered. Of course, chemoradiation and the surgery is still an option. Because endoscopy resection for this kind of lesion have higher risk of stricture. So we need prevention of stenosis. The NCCN guideline also show for the superficial lesions, endoscopy therapy is preferred. However, he also mentioned that esophagectomy is indicated for patients with extensive superficial lesions based on the high risk of stricture after endoscopic resection. The logistic data from Japan show that for the superficial esophageal cancer, the survival is good for the endoscopic resection or operation, but the survival is not so good if you choose the CCRT. However, the esophagectomy, the operative and the peri-op mortality is around near 5%. The data from Korean also show that the OP and CCRT had higher serious complication, up to 9%, but the CCRT have higher recurrent rate. So the data from Korean show that endoscopic resection and esophagectomy has similar survival for the superficial esophageal cancer. So for this kind of lesion, we could choose ESD. We could also choose esophagectomy, depend on what kind of factor you will consider. So for this patient in my hospital, we choose the ESD. This is the final pathology of the lesion. Although the biopsy show only high-grade dysplasia, but after analyzing the pathology of the ESD specimen, we could find a micro invasion over one foci. The cancer cell invade the lamina propria. So final diagnosis will be moderate differentiated squamous cell carcinoma with lamina propria invasion. The margin is free and no microlymphovascular invasion. So the ESD is a curative treatment for these patients. So the final pathology is early esophageal cancer with TYA lamina propria invasion post-ESD treatment. So I will show you the post-ESD wound. You can see very extensive wound after the ESD. So the risk of stenosis will be high during the follow-up. So the final question I will ask, will you consider give stricture prevention? What kind of stricture prevention will you give for this these patients? Please vote. Will you give the patient systemic steroid or local injection steroid or preemptive balloon dilatation, or just follow up and give balloon dilatation after stricture developed? Okay, I think most of you choose steroid, local injection or systemic treatment, and some choose the preemptive endoscopic balloon dilatations. Okay, this I want to show you this is the current management for post-ESD stricture. For prevention of stricture, there are some way, including the Botox injection and the anti-inflammatory agents such as steroid, local or systemic give. And some studies show mechanical prevention like preemptive balloon dilatation. This is most popular in Japan. And some study in China, they try esophageal stent. And also in Europe, they have biodegradable esophageal stent. And some studies show regeneration medicine, such as scaffold transplant or cell-based therapy. However, when the stricture formation, then most of the doctor perform the balloon dilatation, or some perform the ANBIIG, incisional therapy, and some may give esophageal stent. But I see most of doctors will choose the anti-inflammation steroid, and many studies show that local or systemic steroid also both have effect on the prevention of the stricture. So this is my final slide. I think periodical endoscopic surveillance of esophagus in high-risk population is crucial for the early detection of esophageal cancer. Using IEE and the application of new JES classification is easy to learn and use, and also with good accuracy, especially for the type B1 and type B3. And finally, I think practice makes perfect. So that's the mission of ANBIIG. We have many series webinar this year. So I think everyone should have more practice in the future. Thank you for your attention.
Thank you so much, Ching Tai. A very comprehensive lecture and discussion. I can see there are actually two questions. So perhaps one is about, do you still perform Lugo staining in all the routine examination? I think it is open to all the panel member. So I think we can actually vote among ourselves. So how about Ching Tai? Do you do routine Lugo staining?
Yes, I still routine use.
Well,
how about Professor Inoue? Are you still doing routine Lugo?
No, so we routinely check the region in the NBI. And the chromoendoscopy Lugo staining is at the time of a diagnosis, a final diagnosis, or in a complicated case. And of course, at the time of a treatment, we use Lugo staining.
How about for Professor John?
Yeah, yes, similar situation in Korea, because we cannot use routinely for the Lugo solution. So with the permission of IRB, we perform Lugo spray during therapy endoscopy only.
And Dr. Gao?
We only perform Lugo solution staining for definite diagnosis, non-routine use.
Yeah, I think the trend is towards not a routine Lugo. Lugo require preparation and also actually induce a kind of discomfort after the procedure, like chest pain. And also there is a blind spot for the Lugo, like a proximal few centimeter in the esophagus is difficult to observe. But I think in Lugo has its advantage of overcoming the expertise. So if you are not expert in the IEE, Lugo helps to detect. So, and also there are multiple questions. I don't think we can answer all, but probably one more question, like what should be the timing of preemptive balloon dilatation after a near circumferential or circumferential ESD, Qingtai?
Yeah, I think preemptive balloon dilatation is popular in Japan. Usually they perform preemptive balloon dilatation within 1 week after ESD. But in Taiwan, we did not perform preemptive balloon dilatation. Yeah, we just give anti-inflammation steroid therapy, and we just follow up, and we give balloon dilatation after stricture developed.
I see. So how about Professor Inoue? What's your comment about preemptive balloon dilatation for management of ESD stricture?
Yeah. So thank you very much. The very important question in the clinically. In our hospital, we do like this. So we check the patient 1 or 2 weeks after procedure. So of course everybody knows. So once the stricture completed, so it's a very difficult to even when we try to make a balloon dilation. Preemptive. So balloon dilation is better. So before patient complain the dysphagia. So of course a mild dysphagia is acceptable, but so before patient complain severe dysphagia, it's better to perform the preemptive dilation.
Thank you so much. And I think because of time, we need to move on. I hope that Qingtai, Dr. Lee can answer the questions listed in the Q&A area. So without further ado, let's move to the next presenter, who is Professor Bunyan Zhong, and he will be discussing his case. And please start.
Okay.
Yes, we can see your slide, Hunyang.
I know.
Yeah, and I think you are now in San Francisco, so a totally different time zone. I very much appreciate you are in the middle of the night. Thank you.
Okay. Yeah, I will present 2 cases. First one is this case, the 58 years old man, and he took regular endoscopy checkup.
Sorry, Professor
Additionally,
Zhong. Sorry, Professor Zhong, you have stopped sharing the slide. Maybe you have to share again.
Okay.
Thank you.
Okay, sorry about that. Okay. Okay, is it okay?
Not yet.
Yeah.
Not yet.
Not yet.
Not yet.
Okay. I'm sorry.
Okay. Yes, it's okay now.
Okay. Okay, first case is a 58 years old man. He took a regular endoscopy checkup. And in addition, he complained of a long history of cold symptoms. And this is a white light image of outside clinic. You can see the discolorated area at 12 o'clock of distal esophagus. And as well as you can see the mucosal break. that should be LA grade A. It is endoscopy finding of our institute. You can see the video and the spot pictures. Yeah, this distal area, discolorate lesion located in the distal esophagus with the skipped normal esophageal wall. And with the ANBIIG mode, you can find dark spots, many dark spots. It may be IPCLs. Okay. Okay. So this lesion is the main lesion, referred the lesion. The biopsy was high-grade dysplasia. But during examination, you can find at the 9 o'clock area, very faint discolorate area here. So conclusively, this patient has two focuses of abnormal mucosal lesion. Okay, so with the ANBIIG near focus, this picture is the near focus view. From the near focus view, you can see very faint the IPCLs, not detailed structures, but can see the spot dots. Okay, and here is a synchronous lesion. So first quiz. What is endoscopic diagnosis of this main and the synchronous lesions? What is the accurate answer? 1, 2, 3, 4. Yeah, very interesting. This is my purpose to make a quiz. Okay, the 40% reply choose the Barrett esophagus and the Squamous neoplasm. Okay. I cannot get this. Okay, please remove this the ankate. Oh. Okay. Yeah, my answer is number 3, because these two lesions are located in the esophageal mucosa. Okay, with the normal esophageal mucosa between the G line and this main lesion. And the flat lesion, it is flat and discolorated without ulcer nor mass. So two lesions are also squamous. This is magnifying endoscopy with ANBIIG system. You can find the IPCLs elongated and thickened and tortuous deep. But here, this proximal area and the distal focus, the mucosal focal hypertrophy area you can find. but with this hypertrophic area has include the loop IPCL. So even this the hypertrophic area, but IPCL changes loop. Okay, so it is spot images. Okay, this is chromoscopy with the Luger. Okay, left side 2 pictures before injection, and right side is after injection. So okay. From the right side image, you can find the more reddish spots in the unstained area. So quiz 2, the worst endoscopic diagnosis of this patient. Number 1 is a Barrett, number 2, low grade, and number 3 is high grade, and number 4 is carcinoma. Okay, almost 40% of participants choose a squamous dysplasia high grade. Yeah. This is my answer. From the pattern of IPCL and the pink color sign after Luger spray, it means high-grade dysplasia and or squamous carcinoma. So the loop IPCL pattern may be suspicious of intramucosal carcinoma. But according to the countries, some countries consider these findings squamous carcinoma in pathology department, but some countries interpret as a high-grade dysplasia. Anyway, intramucosal carcinoma or high-grade. I did perform ESD. Okay. Can find the 2 focuses. Here is the G line. This is a specimen and the mapping sheet. Okay. Yeah, it's 1-to-1 slide. The blue bar is normal squamous epithelium, and the red bar is the lesion. This focus and this focus, you cannot find the invasion of basement membrane. So this is the high-grade dysplasia. Yeah. This is the end of first case. Okay. Do you have any question or comments for this case?
Yes, I have a comment. So thank you very much. A demonstration of the beautiful case. So very interesting. So I like say that this region in an endoscopic view, we can identify the upward growth of the tumor. Looks like, and this is a squamous cell carcinoma. M1, M2, but the it looks like. So would you mind coming back to a histology image?
Yep.
Yes, yes, yes. Yes. So we can see some granular component in histology. So originally squamous cell carcinoma, but it's growing. So like adenomatous component. So it's quite often happen. So this magnifying images demonstrated very well these findings. So any comment from the pathologist that this case is a squamous, but there are some adenomatous granular-like growth of the squamous cell.
You mean this part, right?
Yeah. This part. Yes.
Yes, I asked my pathologist, but he said this part maybe a little bit necrotized with from necrosis. So he said this area maybe degenerated portion, but
Okay.
partly I'm agree with you, but whole this image cannot show the adenomatous the other other part because
yes, I know. So adenosquamous in such a case, the adenoma granular is more compact, so not like this large. But the endoscopy image is a magnifying endoscopic NBI image looks yes. So like this way, so upward growth. And then looks like a papillomatous. In other words, looks like a papillomatous growth, and then in some part create the like granular structure. So I think yes, it's some growth pattern. Yes. Anyway, it's differentiated.
Yeah.
Adenocarcinoma, I think. Not a good candidate for ESD. Thank you so much.
Yeah. Qingtai, do you have any other comment?
Sorry, I'm busy to answer the question about my topic.
Yeah, so just to follow up on the pathology. So interestingly, there's some pseudo-granular appearance of the background. So could that actually be more related to a HPV virus that called a papillomatrix kind of appearance? I don't know. Just a follow-up proposal. But very nice case. I think that's a really good demonstration.
Okay, then I will continue to next case.
I'm sorry disturbing you. So I totally agree. The Philip comment is correct. Should granular structure. Thank you very much, Philip. Nice comment.
Thank you.
Okay. Next case is 71 years old man. He already received esophageal ESD on 2014 October. That time, the size was almost 1 centimeter tumor, squamous cell carcinoma, moderately differentiated, and the depth of invasion was SM2, 0.5 millimeter from the lower margin of muscular mucosa, but no involvement of resection margins and lymphovascular invasion. So this time he received a regular endoscopic checkup. This picture is the previous ESD site. Okay. So around 23 centimeter size, 23 centimeter location, at the 12 o'clock, can see the very small lesion here, and the whitish plaques around the tumor. Okay, so the size is also around 1 centimeter. This is a near focus view and the local staining. So near focus view shows a little bit irregular arrangement of the spots and the linear components of the microvessels, and multifocal avascular area. Okay, and this 1 o'clock area, you can see suspicious visible submucosal vessels. The right side is chromoscopy, the lugal void lesions. Okay. So quiz 1, what is the endoscopic diagnosis of this patient? Okay, let's start. Most of the participants hesitated to choose one. So 1/3 benign and 1/3 mucosal cancer and others submucosal cancer. Yeah, I understand. Because of the size issue, maybe dysplastic or mucosal, but the suspicious submucosal vascular structures means the submucosal invasion. Anyway, oh, okay. Yeah, the answer is submucosal cancer, because the by endoscopy you can find the protruded lesion and the mass effect like submucosal tumor-like, and can see the coarse granules at the right side of the tumor and the lugal void lesion. So, okay, I will, okay, can see that this main tumor is elevated and protruded, and some proportion, the lower margin looks like a SMT shape. So these are suspicious of submucosal cancer. But I don't know exactly, but these findings are very important. Okay. This is ANBIIG magnifying endoscopy. Okay. Focus on the IPCL. Okay. Very different from the first case, right? So this patient has elongated and loop vessels, but this area is suspicious of submucosal vessel, and here is the non-neoplastic area. Okay, then can compare that area and here the lesion. Okay, avascular area here, and some IPCRs are destructive at this point. Okay. So anyway, the IPCR patterns are mixed with the thickened and loop vessels and non-loop vessels, and some focus of destructive IPCRs and the multiple avascular area. Okay. So, so how about this case? Oh, I'm sorry, this is case number 2. From these findings, what is the endoscopic diagnosis? Okay. More than half change and choose the submucosal cancer. Okay. Yeah. This is the summary of this endoscopic finding. Loop and non-loop vessels and the distracted and the visible submucosal green vessels and the relatively large avascular area. So endoscopic diagnosis should be submucosal cancer. Because he denied the other surgery or other treatment modality, and the size is very small. So we decided to take ESD. Okay, this is ESD picture. And it is pathology findings. The 1-to-1 slide here. Yeah, that grossly you can diagnose. This is SM2, right? Here. Yeah, the tumors are embedded into submucosal area, the submucosal layer, and also embedded into the submucosal esophageal glandular structures. Okay. And this patient has lymphovascular invasion. So the size was 15 by 10 millimeter, and SM2 invasion, and the lymphovascular invasion positive. So this patient considered the non-curative resection, and then this time he performed adjuvant chemoradiation therapy after ESD. Okay, this is last presentation slide of the second case.
Thank you very much, Professor Zhong. I think we can probably cater for one question. So we can see there's one interesting question from the audience about patient have history of GERD, and also the diagnosis is squamous cell carcinoma for your first case. So do you think there's any correlation between these two?
I don't think so. Because the two entities, the squamous cell carcinoma and the Barrett adenocarcinoma, is different in terms of etiology and the pathogenesis. So, okay, I will show the first case. Okay, here, the main lesion located in the esophagus here, but mucosal break is 2 to 3 o'clock area. Okay, so this mucosal break and the discolorated main lesion is independently developed because two lesions are not related in the geographical relationship.
Yeah,
And
I
he
think
has,
So I think this is an important lesson to learn. That the patient may present with GERD symptom. You might find erosive esophagitis LA class A, but adjacent to these inflammation, there could be a hidden squamous cell, dysplasia, high-grade dysplasia. So you can never assume that a patient with a GERD must have Barrett's esophagus or any other. So we have to be open mind. And I think this is an important lesson.
Yeah.
Thank you so much, Professor Zhong. So I think we have to move on because of time. And the next, our next faculty presentation will be from Dr. Cao Chen Yagao. So please start your presentation.
Okay, so can you hear me now?
Yes.
Can you see my slide? Okay.
Yes.
So thanks for Professor Lee's introduction, and it's my pleasure to share a struggling case here. I'm Dr. Guo Zhenya from Furen Catholic University Hospital in Taiwan. And this is a 60-year-old man without systemic disease before, and he presented to my GI clinic with acid reflux and epigastric pain for weeks. And he has a personal habit of chewing betel nuts, smoking, and drinking for years. So EGD was arranged to rule out esophageal lesion. And under white light, there was a ill-defined hyperemic mucosal lesion at the middle esophagus. And in the near view, we can see the lesion surface was uneven, and there was a large nodule component on it. So my first question for the attendees is that what is the circumferential extent you expected on the white light? And is it a whole circumferential or non-circumferential lesion? So please vote. Thank you. Okay. So, okay, okay. So, yeah, the vote. Most of them, most of you choose the non-circumferential lesion. Yes, because white light is not very clear, so maybe we need endoscopy for further definition. And under the non-magnified NBI, the mucosal lesion margin became more clear, and it presented as a well-defined semi-circumferential brownish area, and the color of the nodular part was paler than the background mucosal lesion. And under magnified NBI focusing at the peripheral flat region, the left upper picture showed the dilated and irregular shape of the IPCL. In the right upper picture, we can see some avascular area and circled by the microvessels. In the lower two pictures, focusing on the uneven part, and we can see some non-looping microvessels on the nodular surface. And when we focusing on the large nodular part, and we can see many non-looping microvessels with larger avascular areas. So my next question for the attendee is, what is the most advanced IPCL classification for this lesion? Yeah, please vote. The first one, type A, B1, or B2, or B3. Okay. So yeah, most of the attendees choose type B2. So is there any comment from Professor Inoue or Professor Zhong?
So, thank you very much. It's a very interesting case. So point is a let's go back to our nodular part. In the middle of the nodular part, we can see a depressed area. So what I mean is so depression, well, like a list, we can see it. Now, other slide, we can see magnify. Yes, this one. So left bottom, you can see there are two upgrowths on the center. You can see a concavated, depressed area. So in this area, so maybe the most deepest area. So we can say this part is the not B3, but lots of non-loop vessels. So of course, some water is cover the surface, so a little bit unclear, but anyway, so we can say lots of B2 vessels. So and then the B2 vessels cross relation to some component, some portion is submucosal invasion. So I think this is the case.
Okay, so I have a question for Professor Inoue. Is this B3 microvessel?
No, I don't think so. This is so it's a very difficult. You may like because surface you can see a brownish, so a little bit left up. So yes, so we can see AVA, the center of this image, AVA, and then surrounded with the brownish small vessel. And the behind, we can see a green, relatively large vessel. So this is in the region and the center of the region. So we can say this is a B3. Yeah, but yes, but always a B3. If it's exposed to the surface, it's easy to say. But like this case, it's a little bit complicated. But we can say this is B3.
Okay. Okay, so the patient also received chromoendoscopy with Lugo solution, and now we can clearly identify the extension of this lesion. The lesion presented as a Lugo voiding area extending more than half of the circumferential. And 2 minutes after spraying the stent, the lesion showed some pink color change. And except the main lesion, there were multiple small leucovoiding lesions at the rest of the lesion of the esophagus. So this is my next question. So what sign did you see on this chromoendoscopy with Lugo solution? And this is a multi-choice question. Okay. Okay, so yeah, most people choose pink color sign and leopard skin appearance. So Professor Lee, could you explain what the importance of leopard skin appearance in your experience? Because there are many, yeah.
Please show the picture. Yeah, the background are multiple small leucovoiding lesions over the background. Some of the leucovoiding lesions may be near half centimeter. So this is so-called the leopard background. This means this patient had a high risk of recurrent metachronous esophageal cancer after treatment for the main lesions. So in my unit, this kind of situation, we now try some prevention for the background of the mucosa.
Yeah. So maybe after ESD, you will use RFA to eradicate
It's
the rest of
still
lesion.
under study. Yeah.
Yeah, it's still under study. Okay. Okay. So we also performed mini probe EUS for this patient, and we can see the mucosal lesion presented as irregular thickening of the second layer of the esophageal wall, and in the magnified view, there seems still a little submucosal layer still can be observed. So this is for attendees' question. So what is the invasion depth of this lesion? Yeah, please vote. Thank you. Okay. Yeah, so half of the attendees choose MM layer to S1 layer, and 40% choose the SM2 invasion depth. Okay, so let's see. Because this patient did not have any dysphagia, any symptoms, so and under the impression of the endoscopic diagnosis, we highly suspect invasive cancer. So we took biopsy at the large nodular site where we think the most advanced lesion is. However, the biopsy pathology only showed high-grade dysplasia because there was no stromal tissue could be found in the biopsy specimen. So we also performed some staging images, including the contrast CT and PET CT, and there was no evidence of lymph node metastasis or distant metastasis. So what's your treatment plan for this patient? Please vote. Will you transfer this patient to surgery, esophagectomy, or diagnose ESD? It's very expensive for Taiwan because it's not included in our national insurance, or EMR for deeper specimen for pathology diagnosis, or directly chemoradiation therapy. Yes, okay. Yeah, so most attendees choose ESD. Yeah. However, in our endoscopic diagnosis, we think this may be deep invasive esophageal cancer. So, and the diagnosed ESD is very expensive in Taiwan. It's cost around more than $3,000 in Taiwan, and an esophageal cancer patient mostly chewing betel nuts, so they are working level, so their economic status is not very well. So this patient, we choose EMR. After discuss with the patient, we choose EMR for deeper specimen for pathology diagnosis. And how, is there any comment from Professor Inoue or Professor Zhong?
So it is expensive for the diagnosed ESD, but
Yeah.
EMR for deeper portion, suspicious deeper portion.
Yes.
Yeah, is if the EMR result report M3 or M2, it may interfere the full therapeutic ESD.
Yeah.
So
maybe,
I think the diagnosed ESD is worth it to perform,
yes.
in spite of high cost.
Yes. So is there any comment from Professor Inoue?
It's a very difficult to comment. So it's a very special occasion. So ESD, the self-payment is very expensive. So it depends. So, case dependent. So what the patient want to. So yes. So EMR for deeper specimen for pathology diagnosis is one of the choice. But yeah, it's very difficult to comment.
Yes, I see.
Treatment
So,
for this patient.
okay. So after discuss with the patient, we decide to use EMR for deeper specimen. And however, during the procedure, the elevation is not very well, so we cannot grab too much specimen. And the ligation EMR pathology only showed high-grade dysplasia again, and because no stromal tissue could be found. Yeah, so 1 month later, the patient came back to my clinic. Yeah, because after the ligation EMR, we encountered the Chinese New Year, so the patient wished to make the decision after the holiday. And so 1 month after the ligation EMR, he come back to my clinic and finally decided to choose ESD, diagnose ESD. Before ESD, we repeat the magnified NBI and chromoanoscopy. And we can see some B1 and B1 loop IPCO and the vascular area at the peripheral part, and B2 IPCO pattern at the nodular part. And no obvious B3 vessel was seen at that time. Okay, and we can see after the ligation EMR, the previous EMR site was re-epithelialized by the normal epithelium. Okay, so again, what the invasion depth do you expect at this time? Okay, this is not the question. Okay, maybe 1, 2, 3. Yeah, maybe the option is wrong. Okay, so okay, this is the right option. Okay. So now most people think this is a MM or SM1 lesion. Okay, so so this patient finally decided to choose ESD, and the final pathology it was this picture, and we can see most of the malignant cell were confined in the lamina propria layer. However, and this white line shows the level of muscularis mucosa. And however, there is a small foci of some mucosal invasion. And under magnified view, we can see the malignant cell break through the muscularis mucosa layer. And the submucosa invasion depth was around 200 micrometer. And there was no lymphovascular invasion, and the vertical and horizontal margin are free. So the final pathology diagnosis was a poorly differentiated squamous cell carcinoma. It's a pathology stage in T1B SM1. Okay, so what's your further plan for this patient? Yeah, please vote. Okay, so very interesting. The third the three options were almost equal. Yeah. So yeah. How about your experience, Professor Lee, on this situation?
According to the new guideline from Japan Esophageal Society, cancer invaded to the submucosal layer. Although there is no lymphovascular invasion, the risk of metastasis, lymph node meta, is still high. So they suggest adjuvant treatment, including the surgical resection or chemoradiation.
So because this patient did not have any symptoms, so I think most patients won't receive the esophagectomy. So in your experience, is there that so much patient recurrence in your experience?
Yes, we do have some patients, they choose surveillance, but lymph node metastasis developed during the follow-up.
Yes.
So usually I will encourage patient at least to receive the radiation.
Chemoradiation.
Of course,
okay.
chemoradiation is better. Almost no patient choose esophagectomy.
Yes. So how about Professor Inoue's experience?
Yeah, it's always very difficult. So, so in this case, pathology demonstrates a purely differentiated. So, the true G3, it's like yes, purely differentiated cancer cells. Yellow line is here, but I think covered with some. It's a very difficult to reaction or some, but we can. So your pathologist said that this is the front line.
Yeah, they say this is the inflammatory cell, maybe lymphocyte or neutrophil. This is the tumor cells.
Okay.
Yeah.
So, but anyway, so probably differentiated squamous cell carcinoma. So I think yes, I recommend chemo CLT or surgery. But so esophagectomy is always invasive, so totally different from a gastrectomy. So we talk to the patient and decide everything the patient opinion, patient request.
Yes. So
Patient decision. Yeah.
Yeah. How about Professor Jones' opinion?
Yeah, because his age is 60.
Yes.
And the differentiation is poorly.
Yes.
And the invasion depth is SM1.
Yeah.
So I'd like to recommend surgery strongly because first one is differentiation. So the chemoradiation therapy can effective as surgery, but cannot convince the residual potential lymph metastasis. And secondly, the radiation therapy is also another risk factor of esophageal cancer. So the age of 60 is relatively young for the esophageal cancer. So for the long period of low evidence of disease status, surgery is better than chemoradiation. If this patient has differentiated cancer, either way, okay? But undifferentiated cancer can transform to small cell carcinoma.
Okay.
So yeah.
Okay.
So same as me, I also support surgery. Not because I'm a surgeon, but also because I think that's the most definitive way to ensure a good curative, intent treatment. Although I know that now, in Japan, they have already run a randomized trial comparing these cases with a chemoradiation therapy against surgery, but probably, I guess, before any results coming up, the surgical treatment will be quite, ensure the clearance. But I also understand a lot of these patients actually do not want surgery after they hearing and listening to the explanation about esophagectomy. Then I guess a chemoradiation is the alternative.
Yes, I also comment. I agree. So age over 60 and not so weak. So in such a case, poorly differentiated, and it's better to do lymphovascular involvement, D240 or some other staining, special staining, and then confirm the vessel invasion. And anyway, so poorly differentiated SM1. So good candidate, age of 60, good candidates for surgery. Yes, you're right.
Okay.
And can I comment a little bit? So
Yes.
In a magnifying endoscopic view, I said the large green vessel.
Yes.
It looks like a elevated component. It looks like a B3. It's a discussion, and in this magnifying endoscopic view, still I can say this is a B3. And then please coming back to the theoretically, so B3 vessel is a correlation to our sub SM2. So please come back to our pathological image, histological image. Thank you so much. Thank you so much. So in this case, as the most important is the theoretically corresponding to SM2. So, but the B3 vessel originated from the branch vessel that is located at the level of the muscularis mucosa. So in this case, some enlarged vessel, yeah, that's right. In this area, so enlarged vessel is coming up to the close to the top. So so this vessel may be corresponding to the green vessel in a magnifying endoscopic view. I'm not sure, but the such kind of a feedback from the histological image is it's very important. So misleading of the I don't think a misreading, but the so always misreading is not an issue. So always we have to be corresponding, compare the endoscopic magnifying diagnosis and the histological image.
Yes.
Thank you.
I have another question. Professor Inoue or Professor Zhang, do you think, because this patient received EMR first and then scarring and reabstination after healing, do you think the IPC is still reliable after EMR?
So before treatment, before EMR, so elevated component may be the deepest area. So it's a little bit difficult because elevated area, it's upward growth. So sometimes evaluations are very difficult. But in this case, I think elevated area is the deepest, I think. But so my question to you is the deepest area is corresponding to the previous EMR position?
Because the pathology in Taiwan, we did not do the mapping. Yeah, so we cannot identify which side is the deepest part. Yeah, I'm sorry. Yeah, it's very difficult to persuade them to do mapping.
But from the left bottom of the picture, the previous EMR site seemed to be covered by the normal reabstination squamous cell.
Yes. So I
But
think maybe the deepest side is here.
Beneath the regenerative epithelium, So there may be the cancer. So
Yeah, maybe.
it's the same to Barrett's.
Okay.
Yes.
Berry cancer.
Early cancer may happen. So yeah, it's a very difficult without mapping.
Yes. Okay, so that's my presentation today. Thank you.
Thank you so much.
Thank you so much. Very nice case.
Yeah, so I think we have gone through a really nice panel of cases, and from various types, and there's a lot of learning points from all these cases. And I think probably we can entertain also still one more question before we end the session. So there's one interesting question about after chemo radiation, how to evaluate for residual or recurrent cancer. So any idea from our panel?
In my opinion, if the patient did not receive the esophagectomy, he received the chemoradiation. During the follow-up, my experience, the IPCL is become difficult to decide what kind of IPCL after chemoradiation. So during the follow-up, I routinely use the local staining to check if there are any local residual or recurrent lesions. And of course, I will regularly arrange CT scan to check the lymph node status. Yeah, it's my opinion.
I totally
Most
agree with
important-
you. Yes.
Yeah.
Can I say? Of course, after CLT, endoscopic image is of course modified. So we follow the patient every 3 months in such a case. So in some case, particularly in the case of the CLT effective case, so recurrence may happen, recurrence or residual tumor may happen. It's like a M1 style, so like a M1. In such a case, we can identify the tumor easily. Not easily, but relatively easily. But in some case, recurrence happen in a SMT-like. In such a case, the surface has no change. So just the NBI examination not enough to identify it. But the of course, the same to other SMT, we can find the elevation of the mucosa. So we can suspect. So combined with the CT and the evaluation together, the lymph node involvement is most important. Thank you so much.
Thank
So
you.
yeah,
Yes.
my comment for the PET-CT scan of last patient,
Yes.
especially for the mucosal cancer, it means candidate for the ESD has low, cannot detect the tumor location from the PET-CT scan. So if you could find the mass-like or any kind of lesion at the site of a tumor from the PET-CT scan, the possibility of some mucosa or more cancer. So a PET-CT scan is usually detect the metastasis, but my utilization is the visualization or non-visualization. That critically, that question is very important for the reading, for the interpretation of PET-CT scan.
Yeah. Okay, so this patient, we arrange PET-CT is to detect the lymph node metastasis because we want to persuade the patient to go surgery. Yeah, so we arrange the PET-CT scan.
Mm-hmm.
Yeah. Okay,
Right.
thank you.
Thank you so much. And I think with all the interesting questions and answers and also case discussion. I think we have to end this session because it's already 6:40 in Hong Kong. So really nice having all of you here, and especially thank you, Professor Haruhiro Inoue, Professor Hu Yanzhong, Dr. Ching Tai Li, and also Dr. Chen Yi Guo for all this great contribution. So please stay with us for this clinical case marathon, and we will extend our invitation from March all the way to August. So thank you so much for all your attendance. Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Bye-bye. Bye-bye.
Oh, great cases.
Bye-bye.
Thank you so much.
Thank you.
I enjoyed.
Thank you.
Bye.
Bye.
Bye.